I've tried to cut this down. I actually had 6 studies, but in the interest of time, I cut it to 5. Just there was so much information to talk about, and I wanted to try to be respectful of the 30-minute window. So these are my disclosures. And the first trial that's very interesting is the Endurance trial. And there's strong data about the best induction therapies do impact long-term outcome after myeloma. And the standard of care has been in the U.S. bortezomib, lenalidomide, and dexamethasone. And there is a trial from the SWOG study that shows improved outcomes with this combination. But carfilzomib is a second-generation PI, and there are phase 2 data that suggests it's more effective than bortezomib. And so this was a trial designed to directly compare bortezomib or carfilzomib along with lenalidomide and dexamethasone for initial therapy in newly diagnosed multiple myeloma. And this was designed to have previously untreated patients. This was not designed to transplant patients as part of the initial therapy. They could have their stem cells stored and could be transplanted at relapse. It also excluded a number of high-risk patients by FISH, by high LDH, or patients with plasma cell leukemia. Other than that, the eligibility criteria are fairly standard. And so basically the trial design, as you can see here, was a straightforward comparison of VRD versus KRD. The duration of therapy was approximately 9 months. And as you can see, the VRD arm used 3-week cycles, but gave up to 12 cycles. The arm B was KRD with 4-week cycles, but the duration of therapy was the same. And then at that point, patients were randomized to either continuous lenalidomide or lenalidomide of fixed duration of 2 years. But the report was just on the initial treatment part. The primary endpoint was PFS with overall survival and other things as secondary endpoints, including quality of life. So looking at the patient breakdown, as you can see, a third of these patients were over the age of 70 years. And it's worth noting that there were a significant population of African Americans represented in this trial. And a quarter of these patients were stage 3. And keep in mind that although this excluded a lot of the high-risk patients, it did include patients with 414 who are considered to be at least intermediate, if not high risk. It also didn't exclude patients with a high beta-2 microglobulin, and as you can see, there were patients who would be categorized at least as stage 2 or some at stage 3 based on the ISS criteria. So the other thing to keep in mind is that even though this was a large trial with 1,000 patients, patients did not always complete their therapy. 43% completed the planned VRD induction, 61% with KRD. Patients dropped out for adverse events, more so in VRD than KRD, and patients went to alternative therapy that was not well described. In addition, transplant was given to about a quarter of the patients, despite the intent not to transplant these patients up front. But this is the primary endpoint, PFS. And as you can see, there's absolutely no difference in progression-free survival within the first 3 years of the study. For patients over the age of 70, PFS was actually inferior with KRD, 28 months versus 37 months. But with censoring for patients who went to stem cell transplant or alternative therapy, there was absolutely no difference between the two, PFS at 31.7 versus 32.8. When you looked at the subgroup analysis, men actually tended to tolerate KRD less favorably. As you can see, if you looked at cytogenetics, patients with abnormal cytogenetics tended to benefit a little more from KRD, but none of these were statistically significant. When you looked at response rates, there was a difference in VGPR rates, 73.8 KRD versus 64.7 with VRD, although overall response rates and CR rates were pretty much the same. Overall survival also was not significantly different between the two groups. When you looked at toxicities, there was a clear difference. Peripheral neuropathy was much greater and statistically significant for VRD, as you'd expect with bortezomib versus carfilzomib. When you looked at symptoms such as dyspnea, hypertension, heart failure, acute renal injury, statistically there was more of this with the KRD regimen. When you break this down and you look at cardiac, pulmonary, and renal, you can see that there's more grade 3 and even grade 4 toxicity with KRD compared to VRD, whereas as previously mentioned, the neuropathy is greater with VRD. So the conclusion of this trial is that in newly diagnosed patients who are standard or intermediate risk, KRD does not improve PFS compared to VRD, although KRD is associated with a higher VGPR rate, but there are higher rates of neuropathy with VRD, while cardiopulmonary and renal toxicity is higher with carfilzomib. But based on this data, I think it's safe to say that VRD should remain the standard of care for initial therapy of patients with multiple myeloma. The second interesting trial was a SWOG trial that added elotuzumab to a VRD regimen for newly diagnosed patients with myeloma considered to be high risk. Now, as you know, VRD is the standard as previously mentioned, but high-risk patients generally do much poorer due to their more aggressive disease presentation and disease more aggressive characteristics. Elotuzumab is a monoclonal antibody to SLAMF7 and is approved in combination with RD and PD for relapsed refractory patients. But the question was, if you added this drug, elotuzumab, up front in these high-risk populations, could you improve outcome? And to be eligible for this, you had to have newly diagnosed myeloma, and you had to have one of these high-risk features, either gene expression profiling or FISH 1420, 1416, deletion 17p, or amplification of 1q, plasma cell leukemia, or an elevated LDH. And the schema was as follows. It was a standard 8 cycles of VRD or VRD plus the elotuzumab, which was given on days 1, 8, and 15 for 8 cycles. And then for maintenance therapy on the 28-day cycle, patients received the standard VRD or VRD plus elotuzumab given twice per cycle. And patients stayed on this until they progressed or relapsed. These patients, there were a relatively small number on this study of about 100 patients, mainly because these represent a minority of all the myeloma patients. But they seem to be pretty well balanced for all the major characteristics. There were some differences in some subgroups of high risk, 42% deletion, 17 in the RVD, 31% in the group that had ELO, and otherwise they look very much the same between the two groups. This is the primary endpoint, progression-free survival, with a good length of follow-up of 53 months. As you can see, there is absolutely no difference in the outcomes for patients who received elotuzumab with RVD versus RVD alone. This is the overall survival, and while there is a slight trend favoring overall survival for this. It's not statistically different. So basically, let me go back up. I think it's safe to say that elotuzumab does not improve the outcome for these patients who have high-risk features. So the third trial to talk about is the Bellini trial, and we've heard a lot of discussion about venetoclax and how it works. Venetoclax has activity in multiple myeloma and can clearly cause apoptosis in myeloma cells. It's also synergistic with proteasome inhibitor bortezomib and dexamethasone. And the Bellini study was a randomized trial of venetoclax, bortezomib, dexamethasone versus bortezomib, dexamethasone. And it significantly improved PFS and response rates, but there was a higher death rate that was observed. And this was an update of that trial. And I think it's important because this is such a useful drug in a variety of hematologic malignancies. So review, the Bellini trial took nearly 300 patients. It was a 2-to-1 randomization between the triplet of venetoclax, bortezomib, dex, or bortezomib, dex. This is for refractory, relapsed multiple myeloma, 1 to 3 prior lines of therapy, and you couldn't be PI resistant to get on this trial. So this was the PFS, and as you can see, the triplet with venetoclax was significantly better in terms of PFS, median PFS of 23 months versus 11 months versus the doublet. The overall survival was not statistically better, however, even though there was a slight trend favoring venetoclax. And that's because of the large number of deaths that were seen in the triplet arm compared to the doublet arm. So as you can see, infections were seen in 5% versus 0, and other deaths 2% versus 1. When you looked at overall survival by subgroup analysis, there was clearly a trend if you were 11-14 positive. Other than that, there weren't any major differences that were seen. When you broke it down by patients who are 11-14 positive or express BCL2 at high levels, you can see that the PFS was significantly better. But if you didn't have 11-14 or BCL expression at high levels, there was absolutely no difference between the two. When you looked at overall survival with 11-14 or BCL2 high, there wasn't any difference in overall survival. But if you were a low expressor of BCL or 11-14 negative, actually the doublet was superior in terms of outcome. The survival was better than if you received the triplet. And when you look at this, it gets back to these problems with infections. There was significantly more neutropenia that was seen here, 25% neutropenia seen here versus 10% with the doublet. So venetoclax clearly caused more of the neutropenia, and this probably led to the higher infections that we're seeing, grade 3 or greater, 38% versus 27%, and serious infections, 32 versus 28. So the conclusion of this was that venetoclax added to bortezomib and dexamethasone improved PFS and actually improved MRD negativity, not shown here, but resulted in an increased mortality. This was probably due to the higher proportion of infection deaths in the venetoclax arm. There was clearly a benefit in the pre-specified 11-14 positive patients. And I think the takeaway here is that venetoclax is a very useful drug, but because of issues with neutropenia, it probably makes sense that patients treated with this drug should receive antibiotic prophylaxis. And I think if that had been done in this trial, you probably would have a different outcome in terms of overall survival. But the Bellini trial does support further research into marker-driven approaches, showing here that if you're 11-14 positive, you clearly can benefit in terms of disease control with the addition of venetoclax. So turning to the fourth study, this is a phase 1 study that I thought was interesting using a B-cell maturation targeted BiTE molecule, so-called BiTE molecules because they're bispecific T-cell engagers. And just in review, these are engineered molecules that combine an antibody to BCMA and a CD3 targeted antibody to produce a hybrid molecule that's able to bind to the myeloma cell by virtue of the target BCMA and then recruit a T cell that otherwise would not be able to target the myeloma cell and provide killing. Some refer to this as, if you will, a CAR T cell in a vial. But these are very promising molecules. There have been several others reported at ASH, and this is another one that I wanted to highlight here. This particular phase 1 study is what has been reported here. They used a step-up dosing to reduce the incidence of neurotoxicity and CRS. Patients were given pre-medications, but they received, initially, as you can see, dosing from 0.3 to 19.2 micrograms per kilo, all the way up to 720 micrograms per kilo. And patients basically received the step-up dosing with split dosing of the initial dose in the first week, and then after the first week, were able to receive the full dose in a continuous fashion. And what I'm going to show you is just this part 1 of the study. So these patients, 78 patients were reported here. They were very heavily treated, median of 6 prior lines of therapy. 80% were triple-class refractory, and a large number were refractory to their last line of therapy, 86%. And 41% are so-called penta-refractory. So these are very heavily pretreated patients. When you looked at the toxicities, hematologic toxicities, of course, were frequent with grade 3 and 36, 38, 24, and 13%. Cytokine release was common, but very little to no grade 3 or greater CRS. And that's because, I think, of the step-up with split dosing. Infections were fairly common, as reported here, but most of these were grade 1 and grade 2. Neurotoxicities were seen in 6 patients. 4 had grade 1 to 2, but there was one was a DLT, grade 4 delirium, and another grade 3 mental status change in a patient who was getting concomitant radiation for a new orbital plasmacytoma. So looking more carefully at the cytokine release syndrome, 56% of patients had CRS within 1 to 3 days. Usually it only lasted a day. And with appropriate agents, tocilizumab, steroids, vasopressors, and oxygen were managed. The use of oxygen and vasopressor was relatively low, as you can see. There did not appear to be a difference between the lower doses and the higher doses in terms of overall grades of CRS, although perhaps a little more grade 2 with the higher doses of this agent. When you looked at responses, though, the responses were pretty darn impressive. 67% overall response rate at 270 micrograms, and the lower doses, 30% overall response rate. And keep in mind, these were patients that were very refractory to their prior therapies and pretty much had run out of treatment at this time. This looks at the responses among all the patients, and as you can see, although the data is still fairly early with only about 9 to 10 months of median follow-up, there were some patients that were responding out a year or more than a year from this. So I think this is a promising new strategy using these BiTE molecules with manageable CRS events, very high response rates. They haven't observed dose-limiting toxicities as high as 720 micrograms. And some of these patients who achieve CRs achieve MRD negativity. So I'd like to update CAR T-cell, and I'm going to just talk about the KARMA trial with BB2121 in the interest of time. So this is one of the trials that's furthest along in multiple myeloma using CAR T-cells. The target is BCMA, the same as the BiTE molecule I mentioned. This has turned out to be a very good target for patients with multiple myeloma. But this ide-cel treatment included 128 patients, a median age of 59 years. And these patients were, again, a pretty bad bunch, 6 years since time of diagnosis, 6 prior therapies with a median a range of 3 to 16. Almost all the patients had had autologous transplant. And all of these patients were refractory, 94% CD38 refractory, 84% triple refractory. So again, a very heavily pretreated bunch of patients. When they looked at response rates, as you can see, there was a dose effect here at the 150 million cell dose of CAR T cells. The responses were 50%, at 300 million, 69%, and at 450, 82%, with relatively high rates of CR, 39, 29, and 39% at the higher doses. So looking at subgroup analyses, clearly there is a dose effect. This is the lowest dose with not much of an effect, but at 300 and 450, definitely a benefit. All the other subgroups, age, sex, ISS stage, there wasn't a difference. There did appear to be a trend, though, with tumor BCA expression. If you were a high expressor, defined as 50%, these patients seemed to do better. If you were a lower expressor, you still could respond, but less so. Very small numbers, though. Look at this, only 3 patients in this group. So I'm not sure that's terribly meaningful. This looks at the expansion, and the responders tended to have higher expansion in terms of the T cells. The other thing to keep in mind is that while these cells could persist out to 12 months, you can see there's a clear fall off in the numbers of these cells starting at about 2 months out to about 9 to 10 months. And this is important, I think, for outcomes for this. These cells don't seem to persist long-term, except in a very few patients. And this, I think, affects PFS. This looks at the target dosing, again, emphasizing that the lower doses seem to be less effective. This is the 300 dose. This is the 450. And clearly, PFS is much better. But as you can see, by 12 months, there is a fall-off, and it's not clear that there's a flattening of these curves. This looks at response rate. So clearly, if you get a CR or stringent CR, you do the best. But again, sometime around a year, there's a fall-off significantly in the outcomes for these patients. So it isn't clear, though, even though the responses are dramatic, and these are very heavily pretreated patients, I don't think it's clear there's a plateau in the PFS curve yet. So I think this is an important point to make. Overall survival at 12 months was 78%, which is really very good for these heavily treated patients who would expect to have a survival of only 3 to 5 months when you're this heavily pretreated. And then this looks at the CRS. As you can see, CRS did occur, and there's a tendency at the higher dose to get a little more grade 3. These are just single patients that got grade 4 and grade 5. The onset occurred fairly rapidly. 2 days and 1 day, and the duration was 4 days and 7 days. Tocilizumab and corticosteroids were important for the management of CRS for these patients. In terms of neurotoxicity, as you can see, there's a bit more neurotoxicity that we're seeing grades 2 and a few grade 3s that we're seeing. The median onset was 2 days and 3 days, and duration was 3 days and 5 days. Tocilizumab was used more frequently for this. Basically, as more and more patients were treated, they learned to manage these toxicities better. And so I think the mortality from this, while there was some mortality early on, with better management and better experience, very few patients die from these complications. And so this KARMA trial demonstrated frequent and deep durable responses up to a year in heavily pretreated patients. The duration of response was 10.7 months. The duration was 19 months in patients who achieved a CR. And the overall survival was 19.4 months among all the patients, highest at the higher target dose of 450. And these toxicities seem to be tolerable and manageable. The outcomes are definitely better than what you'd expect for other highly refractory patients. And with that, I'll stop in the interest of time. These are my conclusions. I think VRD should remain the standard. It does not improve outcome to newly diagnosed patients and refractory relapse patients. And venetoclax definitely improves outcome for the 11, 14 positive myeloma patients. This new BiTE molecule has promising single-agent activity, and the BCMA CAR T cells are very good and very high response rates, but beyond 12 months, the long-term remissions appear to be less frequent, and we don't know yet whether anyone can be cured with CAR T cells with multiple myeloma. And this is in distinction from the data that's been reported in lymphoma, which looks very promising for cures for some patients. I'll stop.
Great. Well, thank you, Bill. That was an excellent talk, and it's nice to see all these emerging options for refractory myeloma, which is a very, very challenging situation. Does anybody in the audience have any questions for Dr. Bensinger? So maybe, so Dave, while you pull up your slides and all, so maybe I'll just ask Bill one question. Bill, do you see any significant difference in the kinetics of response between the BiTE molecule versus the CAR T cells, you know, given how they're trying to use T cells from different sources? And also, is there a correlation of response with the expression of the antigenic target on the cells?
Yeah, as far as the kinetics of response, I think the BiTE molecules tend to work a little more slowly, and keep in mind that patients continue on treatment and receive their molecule either weekly or every other week. And so while usually the majority of patients who get CAR T cells have their maximum response within the first 30 to 45 days, I think it can take up to 60 to 80 days for the patients who get BiTE molecules to respond. But keep in mind, these are very early data, with many of the trials still being in phase 1 with dose escalation. And so I don't think you can compare the two quite the same. I'm sorry, the other question you asked that I forgot.
Yeah, correlation of response with the expression of the antigenic target.
With very few exceptions, there hasn't been a good correlation with BCMA expression. I showed you that one bit of data from the KARMA trial where there was less of an effect with low BCMA expression, but that was only 3 patients. And so the majority of patients have reasonably good BCMA expression, and I don't think there's a a clear correlation that we've seen for this.
Great, thank you. And Dave, I see your hand raised. Do you have a question for Bill?
Yes, thanks, Challenger. Bill, just a quick question. So VRD and elotuzumab has no benefit for the high-risk patients. Does daratumumab have a benefit in that context, or what do you do for those high-risk patients as part of induction therapy?
Well, that remains a challenge. Daratumumab is being used more and more upfront, but I don't think there's good data to show that daratumumab is better than any other agent when it's used in that context. This is still a very challenging group of patients. I actually, even though I presented the data from the endurance trial that carfilzomib was not any better than bortezomib, I do believe that for many of the high-risk patients, that carfilzomib may be a better drug to use. And keep in mind, the endurance trial excluded most of the high-risk patients.
Thank you.
Great. Well, thank you, Bill. That was fantastic.
I have one question.
Oh, go ahead, please.
Yeah. Hello, Dr. Bensinger. This is Yusuf from Michigan. You know, there have been a lot of new drugs that have been FDA approved recently, and I'm trying to wonder where they fit in the algorithm. What about the drugs of belantamab and selinexor? Where do you put that in your treatment algorithm?
Yeah, that's a challenge. I eliminated those from my talk basically in the interest of time. It was just too much material. Selinexor is a drug with fairly modest activity. It has no single agent activity, but it was approved in combination with dexamethasone for pentarefractory patients. So these are very heavily pretreated patients that have run out of treatment. One of the challenges with selinexor is it has a lot of gastrointestinal toxicity, and it's very hard for patients to remain on the drug. Typically, patients have to be given a variety of anti-nausea and appetite stimulants to try to maintain them on the on the treatment. And so it is still a challenging drug to use, but I think for patients who failed multiple therapies, this could be something of benefit. As far as belantamab is another interesting agent. It has high single agent activity of about 30% in patients who failed at least 5 or more lines of therapy. It has one unique toxicity, however, in that there is a high rate of eye difficulties, referred to as keratopathy. And these eye problems are frequent enough, about 70% of patients, and significant, that is grade 3 or greater, in about 40% of patients. They're significant enough that patients who go on this drug have to have eye exams, not only at baseline, but every 3 weeks to stay on the study and to stay on the drug and receive it. So this has a REMS and black box warning for the keratopathy. And I think that's going to be a challenge as well, because these patients have to see an eye doctor literally every 3 weeks, which is the frequency the drug is given. So these drugs are new drugs, and they have activity, but I think they're challenging to give in our patients.
Perfect. Thank